Good evening, everyone. I'm Michelle Batty and I'm EUROGEN's Programme Manager. So just before we kick off, I want to take a couple of minutes just to explain a little bit about what an ERN is and does. So EUROGEN is one of 24 European reference networks which were created by the European Commission in 2017, and they're also funded by the Commission. So we're currently a network of 56 healthcare providers in 20 member states. And the aim really is to collaborate in order to deliver quicker specialist evaluation and more equitable access to high quality diagnosis, treatment and care for patients with rare urogenital diseases and complex conditions. And they're patients who mainly need highly specialised surgery where the expertise is rare. So in order to do this, we can run virtual consultations. I do encourage any healthcare professional who is based in a European Union member state can ask our experts to give advice on a particularly tricky or complex case. And this is free of charge and it's done via a secure system which was kindly provided by the European Commission. So do bear that in mind. We would welcome requests for case discussions. We also collaborate with training and education activities on clinical guidelines as well, again in the rare and complex areas. And we're also writing a book which will be published by Elsevier on rare and complex urology in February next year. And finally, we have a patient registry, which is very exciting. It's just being rolled out across all our healthcare providers. So we hope that quite quickly in the future, with economies of scale, we can collect data at European level on these rare and complex patients. So this evening, we are delighted to welcome really what is a panel of world experts who are going to talk to us about the assessment of male fertility in congenital anomalies. So thank you all so much for giving us your time. The presenter is Gunter De Win, and he's from the Adolescent and Reconstructive Urology Department at the University Hospital of Antwerp. He's also an honorary consultant urological surgeon at the University College Hospital's NHS Foundation Trust. And then we also have a wonderful panel who will be discussing the case discussions. We have Yves Deruyver and Kris Peeters, both from the University Hospital of Antwerp, and Pippa Sangster from the University College London hospitals. So you can see the range of experts we have, which is fantastic. And today's webinar is kindly supported by the European Society for Paediatric Urology. And I hope you enjoy it, and please do send questions. It's a great honour to have these experts with us this evening. Thank you.
Okay, thanks to for this kind introduction. I'm really pleased to discuss a topic that I personally adore, a topic that I love. I'm an adolescent transitional urologist, and it's always interesting to discuss this topic with many pediatric urologists, pediatric surgeons, patients, and so on. So I'm Gunter De Win. I work in Antwerp, an ERN reference center for congenital lifelong urology, but also in London. We are going to give a presentation about this topic, but before we continue, there are a few cases that I want to go through with you. First of all, we have 4 cases that we want to discuss at the end of the presentation. And you will decide with the poll that Darren is going to show in a few minutes which cases you want us to discuss first in case of time constraints. But before we discuss the cases, we will give a full presentation. The cases we can discuss is about this 40-year-old boy, the blonde guy in the middle of the screen. He comes to the clinic with a bilateral undescended testes. The left one is palpable in the lower inguinal canal, and the urologist performed an MRI scan to find the right testis, and that one is in the right pelvis. His testosterone level is 14 nanomoles per liter. This is the blonde guy. You see his age and his pubertal stage. So this is case 1. The second case is a 25-year-old young boy. He's born with bladder exstrophy, and for those who are not familiar with bladder exstrophy, Episperias complex, you can see it in the picture on the left of the screen. Because of his incontinence and his open bladder neck, he got a closed bladder neck, so we performed the bladder neck closure, and he has a Mitrofanov to empty his bladder. You can see the Mitrofanov in the upper picture. The Episperias was not happy with the size of the penis and the extreme dorsal curvature, and as a result of that, he got an Episperias phalloplasty, as you can see in the picture at the right. You can see the glans of the penis at the top, at the bottom of the penis, and you can see the phalloplasty above. And he has a girlfriend right now. They are together for a few years. They're 25. They are both working, and they want to have a child. Then we have the parents of this 15-year-old who come to the clinic. He has small testis, XXY chromosome, testosterone 13 nanomoles per liter, and the parents come actually to discuss the fertility assessment of their son, and they are not sure if their son masturbates already. And the last case is this lovely boy, a basketball player, but unfortunately a wheelchair-bound spina bifida patient as well. And he just wonders, can I ever father a child? Can I have children? These are the 4 cases that we want to discuss with you at the end of the presentation. My presentation will give a general overview of fertility issues and how we assess them. And then let's go practical and discuss these cases with the wonderful panel that was just introduced. My youngest colleague, Yves Deruyver, Kris Peeters, the embryologist from our hospital, and Pippa Sangster, my colleague in London. Darren, do you want to run the poll?
Yep, okay, so we'll run the poll now, so hopefully we'll see this in a second. So I'm going to launch it now. So you've got the 4 choices of the cases that you describe. So we'll give you around 30 seconds or so to start voting on that. Hopefully you can see it. I can see, yeah, I can see the votes coming in now. That's good.
So based on your answers, Darren will let us know which cases we are going to discuss first, so that the most interesting ones for you, because for us they are all interesting, we couldn't choose. Based on your votes, we will see which cases we definitely discuss as first and second. If we have time enough, of course, we will discuss them all.
Okay, so we've got 75% of people who voted, so we'll give you a few more seconds and then I'll count everybody down and we'll close it there. 78%, so 5, 4, 3, 2, 1. Okay, I'm going to close the poll. So we did have a draw there for a long while, but not a draw. So the results were the 32% 14-year-old boy with bilateral undescended testis, and second 29% the extrophy patient, 26% third for the spina bifida case, and lastly 13% for the spina bifida patient. So I think that's the order.
Yeah, perfect. If you text it to us, then we can put the slides in order. Can I get my screen back?
Yeah, I think you should have it back now. It's back. Yeah, it's back now. It's
okay. All right. As a congenital lifelong urologist, transitional urologist, we deal with a lot of patients: spina bifida, extrophy, cloaca, hypospadias, so on, so on, so on. And actually, once these children grow up, they become adolescents, they become adults, and actually the only thing they want is to be normal. And being normal means having a relation, having sex, having normal genitals, having no scars, having an umbilicus, because many of our extrophy patients, all of them are born without an umbilicus. They want to be continent, they don't want to have to catheterize, but also they want to have kids. And this is actually a pretty interesting study, an American study, and they gave a voice recorder to a lot of their congenital lifelong urology patients. And just at home, when they had certain ideas, certain thoughts, they could record it. And afterwards, in this qualitative research, they looked at what these patients were recording. And actually, when you look at all the recordings, sexuality and fertility is one of the most important topics of the records they did at home. Like, for instance, with me, my girlfriend is getting pretty serious. I don't know if she wants kids with me or not, anything, though. I even don't know if I can do it myself. They want to get a good house, good children, and a good job. And if you go to everything, you see that children is a topic that often comes back. I'm still trying to get hold of doctors to figure out if I'll ever be able to have babies myself. So fertility issues, these are issues that many of these patients are thinking about. Well, I'm in Belgium right now, and fertility is also an issue in the general population. People without any congenital anomaly, they often struggle as well. In Belgium, the numbers from a few years ago, it was one couple in 7 that struggled with fertility issues. So when you think about our congenital lifelong urology patients, they have a lot of congenital issues, congenital problems, anatomical problems, and that comes on top of the fertility issues in the general population. 1 in 7 is quite a lot. Well, the basics of fertility everybody knows. We need sperm cell and we need an oocyte, an egg. And these things have to come together, and then we get an embryo, and then we get a child. That are the basics. When we look at the WHO definition of infertility, it's actually quite clear what infertility means. It's a disease of the reproductive system defined by the failure to achieve a clinical pregnancy after 12 months or more of regular, unprotected sexual intercourse. And there's no other reasons, such as breastfeeding or postpartum amenorrhea. Primary fertility in a couple who never had a child. But so regular, unprotected sexual intercourse, that's pretty important. And we all know that, but do our patient knows that as well? Because to have regular, unprotected sexual intercourse, you need to have an erection. You need to have orgasm. Do our spina bifida patients have erections? Can they climax? Can our epispedia patient actually have sexual intercourse? What about their sexual activity? Is my spina bifida patient sexual active? And what do they know about sex? We all know that in the general population, the knowledge about sex nowadays is quite low in our adolescent boys. They know all these fancy things they see in certain visual explicit media, but the real things that matter, they often don't know. So these basics are pretty important as well. This guy makes it pretty clear as well. There are some people that can't get erections, and then doctors have all these different words, but it's just about the penis. I even don't know if I can get semi-erections, but I don't know if I can ejaculate. I have no idea. I even don't know if I can have kids, and doctors don't talk about it. They also have these weird words, but it's called the penis, it's called the vagina. Grow up, it's just the body, and it's just people being ridiculous, and I don't get my answers. These things matter. So the basic functions, if we look at bladder exstrophy exspadias complex, what about erectile functions? Well, we actually know that our patients mostly have good erections. What matters is the curvature and the length of the penis. And actually the length of the penis matters more to them than the actual curvature. Based on the study by Joshua Vogt, who did an interesting PhD on that, for spina bifida patients, the erectile function depends on their ambulatory level. And most of them are pretty good responders to PDE5 inhibitors if we want to treat erectile dysfunction. What about regular unprotected intercourse and sexual activity? Well, when we look at our bladder exstrophy expadias complex, and that's a review that we did in our London patients and was published last year, they all struggle to have sexual intercourse, but that's just because of performance anxiety, because they have a different body. And many boys without any anatomical anomaly, they have performance anxiety as well. So this comes on top of it. But once they have a stable relation, for most of them, sexual intercourse, often in different positions, is not a big issue. And when we looked at the fertility outcome in our London population that we reviewed, and there were only 13 men that answered, but 8 of them had children that resulted in 15 pregnancies, and only 1 needed a testicular biopsy. But on a side note, the population we have in London, when we reviewed, most of them had a bladder neck closure as well, and that's important to understand these quite good fertility numbers. Spina bifida, it's different. They prefer to have able-body friends. They really worry to initiate discussions regarding sexuality. They start dating by the age of 18. If they smoke, there is a bigger chance that they will have sexual intercourse. But incontinence is one of the main barriers. and they need a stable partner that will increase their satisfaction. But the most important thing is that 91% think, and their opinion is that physicians should start discussing sexuality, whereas only over half of the patients that remembers that they ever had such a conversation with their physician. So that's also important to remember. Second basic thing is the anatomy and the physiology. Yeah, this is a slide of the testes, and we know that in the testes we have our tubules, and then we have the spermatocytes with meiotic and meiotic, and then we get the sperm cells step by step. We also have the interstitial cells and the lining cells that produce testosterone. So that's on a testicular level. And it takes up to 64 days before we have a mature sperm cell. And the maturity of the sperm cell happens actually when the sperm cells travels through the epididymis and the vas deferens. That means that the sperm cell coming straight after the testes is not motile, can't move. But it becomes mature whilst it travels through the epididymis and the vas deferens, and it takes about 64 days. So when patients wonder if they are fertile, of course, a clinical examination is one of the first things we have to do. We have to check the testes, the size of the testes. Do we feel any abnormalities? That's quite clear. We all know that, but please don't forget it when a patient comes with questions. Check if everything is normal, because many of them are not checked at the testicular level. Second thing is the hormones, because also hormones are important for our fertility. Yeah. We have the gonadotropic releasing hormone that has a pulsatile secretion when the puberty starts, and that has an effect on our pituitary gland, and that one will produce FSH and LH when puberty is starting. FSH will have an effect on the Sertoli cells, and then the spermatogenesis will start, and inhibin will be produced. LH has an effect on the Leydig cells, and then testosterone will be produced, and both have a negative effect on our anterior pituitary gland. So FSH, LH, and inhibin, together with testosterone, are actually important hormones to measure when certain patients have fertility issues. And we come back to that when we are discussing about the clinical cases. But this hormonal schedule is pretty important to remember. Then there is sperm analysis. Well, we have the conventional sperm analysis, and then we look at the concentration, the motility, and the morphology of the sperm. But unfortunately, a conventional semen analysis only has a modest value in predicting male fertility. We also have sperm function tests, the famous DNA fragmentation that wins in popularity nowadays. And this is associated with increased pregnancy loss when there is a lot of high DNA fragmentation, but this is not tested that much in our congenital patients. We have done some tests with varicocele patients where we see that the more extreme varicocele patients have a higher DNA fragmentation, but in our congenital anomaly patients, we don't have that much data recording DNA fragmentation. To produce a semen sample, and that's one of the first things we have to do when we want to assess fertility in a certain patient. Of course, we need a fresh sample. It needs to be complete. There is some hygienic measures that need to be there. And it's produced by masturbation. And we prefer to have sexual abstinence during 3 to 5 days so that we actually can evaluate the sperm sample. Well, masturbation, do our patients masturbate? What data we have? Well, when you look at the general data in the general population, young patients below 35, several people do it several times a week, 30%, daily 30%, more than once a day, 10%. So, I mean, there's a high number of masturbation in the general population. And actually, that is not that different in the extrophy population. Also, they masturbate quite regularly. But when we look at the data about masturbation in spina bifida patients, well, the only thing we know is that during their life, they masturbated. But how often and how? No idea. Lack of knowledge. That's what we know about spina bifida patients. So for our extrophy patients, hypospadias patients, general population, it's actually more about controlling the frequency so that we have that abstinence period from 3 to 5 days. But for spina bifida, we don't have that much information. But okay, we ask them to produce a semen sample. Sometimes we have little amounts, little to no sperm cells. And of course, this can be related to certain obstructive disorders, which we are not going to discuss today. It can also be due to retrograde ejaculation because of an open bladder neck. Many of our congenital patients, spina bifida, bladder exstrophy, they have an open bladder neck and have retrograde ejaculation. So then there are a few things we can do. We can give them a treatment to have more antegrade ejaculation, and the alpha agonist pseudoephedrine can be given 60 milligrams 4 hours prior to ejaculation and 1 hour prior to collection, and then we sometimes have a more anterior forward sperm ejaculate. I sometimes prescribe imipramine as well because it has an effect on bladder closure. But if this doesn't work, we sometimes do some sperm retrieval from the bladder. So for retrograde ejaculation, when you have sexual abstinence 3 to 5 days, we can give them 50 grams of bicarbonate the day before, 50 grams the day of the collection. We empty the bladder, they drink 2 glasses of water, then they masturbate till they ejaculate, and then we do a urine sample afterwards. For those who have difficulties to climax, we can give neurostimulation, and neurostimulation has a pretty high success rate to ejaculation, but we need a stepwise approach for that. And unfortunately, we don't have that much data on spina bifida. When we speak about neurostimulation to achieve orgasm, we have a lot of data that comes from the spinal cord injury patients. And from those, we know that actually those who have an intact reflex between T11 and S4 and a dorsal penile nerve, most of them can ejaculate and orgasm well with penile vibratory stimulation. And that are mostly those patients with a lesion above T10. Those with a lesion below T10 don't have an intact reflex system, and then we often need electroejaculation, which I'm going to explain in a few minutes. However, spina bifida is not similar to a complete spinal cord injury. Spina bifida is not a complete lesion of the neurogenic tract. And in my opinion, what I see here in Antwerp, that more of our spina bifida patients have an effect of the penile vibratory stimulation as well. So this is how it looks like. We have the membrane here, and we can put it to different amplitudes and frequency. You can see the numbers over there. Usually, when we stimulate the glands of the penis with 1 or 2 of these devices, we get an ejaculation within 2 minutes. And especially when there's an intact bulbocavernous reflex, we can see it easily. And then we get an ejaculate, which we can start to examine. It's possible to do this at home, but for those with a high lesion, I think it's very important to do it first in the clinic to make sure that the blood pressure is okay. If that doesn't work, or for certain younger patients, also sometimes for transgender patients, we can use electroejaculation as well. And this is actually performed by a kind of anal probe, which we put a kind of electric current on, and it will stimulate the area around the prostate so that it contracts, and then sperm can dribble out, which we collect. We do this, of course, in the OR under sedation. So then we can assess the sperm. So we know already a few things about retrograde ejaculation. We know already about those patients who have difficulties to climax. But as I told you in the beginning, the hormones can be important as well. And therefore, it is important to assess the patient. A patient can have a pretesticular issue of is fertility or infertility. It can be a testicular issue, and it can be a post-testicular issue. But of course, if you assess the semen sample first and you collect a lot of sperm cells, yeah, okay, then you don't have to worry too much about this slide. But if the semen analysis is not okay, then you have to think and to reflect what's going on in this patient. Pre-testicular, testicular, and post-testicular, to try to make the difference and to try to find out where are the causes and what can we do. We have to go back to the slide about the hormones that I discussed a bit before. A pre-testicular patient, that can be the one, like for instance, a Kalman syndrome, a hypogonadotropic hypogonadism as we call it. They have low FSH, low LH, and very low testosterone. Sometimes they abuse testosterone, and then they still have low FSH and low LH but high testosterone. So that's a different kind of patient. When there is a testicular issue of fertility, then we usually have a high FSH because the pituitary gland is stimulating the testes to produce as much as sperm cells as possible. And as a result of that, they will have low inhibin B. And these are the patients like, for instance, Klinefelter, chemotherapy, late orchidopexy patients. And then there is those patients with a post-testicular issue. They normally have a normal FSH, LH, testosterone, and inhibin B, but there is an obstruction somewhere. An obstruction because a ventricular cyst, retrograde ejaculation can be the cause, chlamydia can be the cause, or even in normal patients, we see those with a vasectomy as well. When there is a pre-testicular reason for azoospermia, then we don't perform biopsies because nothing happens in those testes. They are sleeping. They are not producing sperm cells. So there is no reason to do a biopsy of the testes to look for sperm cells in a pre-testicular patient. We have to do something else at first, and we come back to that in a few minutes. But of course, for testicular reasons or post-testicular reasons, we can take biopsies of the testes. What several urologists do, and what I don't recommend for congenital anomalies, is actually do a semen aspiration. They use this through cut needle and they put it through the testes while the patient is asleep, and they try to suck as many sperm cells out as possible, as you can see here. For our congenital anomaly patients, this is not something that I would recommend. It's probably better to just do a normal TZ, which means that we actually open the tunica albuginea, and then we make a small incision in the tunica albuginea. Parenchyma pops out, and we just sample it, and we close the tunica albuginea. And of course, we need to give some food to our swimmers, and then we can bring it to the lab. However, for many of our congenital anomaly patients, micro TZ is probably far better. So we can do the TZ under the microscope with the embryologist in theater that can have a look at all the sperm cells that we can collect. But again, not in a patient with a pre-testicular issue of fertility. What we have to think about is that there is a female side of things as well. Because you can say like, okay, why our patient needs to masturbate and to give a sperm cell? We have cultural reasons against it. But actually, a sperm cell coming out via the urethra after masturbation, as I said, it's a mature sperm cell. It can move around. So it can also swim and go to the egg and try to penetrate the egg. And that's different with a sperm cell that comes out of testes. That can't move, so it can't swim around. Yeah? And that's the difference. There's a female side of things. Intrauterine insemination is only possible with actual sperm produced via an ejaculation. In IVF, we need sperm cells, but we need an egg as well, and we have to collect that egg. And for ICSI, we actually penetrate the egg with a sperm cell. Yeah. Looking at intrauterine insemination, yeah, you normally need a lot of sperm cells to make it happen, but this is the best for the female because the female don't need to be stimulated beforehand. And what you see here is that the results are good if you have a lot of sperm cells, but maybe a bit less when you don't have that many sperm cells. IVF, you need at least 10,000 sperm cells. So you can see here the sperm cells who try to fight, who is the first to get in. But both for IVF and for ICSI, of course, we first need to collect. So we need to puncture the ovaries to collect one of the female eggs. Yeah. So we do a transvaginal oocyte aspiration, sperm preparation, insemination, then the lab work, and Kris can maybe answer you a bit more about this when we are in the discussion. We have the embryo cleavage, then we have the embryo selection, and then we go back for an intrauterine embryo transfer. And you can see that, yeah, it's quite a lot of work. Yeah. And the female side of things, I mean, you see here, they need a lot of hormonal preparation. So, I mean, if we can prepare our patients to produce a good sperm cell that we can use for IUI or a different kind of pregnancy, it will be way better. In those patients with a pre-testicular problem, the hypogonadism patients, I mean, we are not going to take biopsies. We are going to stimulate our patients to make sure that they can start producing sperm cells themselves. Yeah? And this is typical for the Kalman patient, and they have a problem with their pituitary gland. We stimulate them with ICG and FSH, and sometimes we have to do that during several months, evaluate, let them masturbate, collect the sperm cell. All the sperm cells are not up to titrate the ACG and the FSH, and so on and so on. But many of our patients with Kalman syndrome, we can collect sperms after a while of stimulation. And at that time, they start producing their own testosterone as well. But after stimulation and after collecting sperm, which we can do at the moment that they want to actually father a child, or we do it beforehand and freeze the sperm cells, we only do this stimulation to get sperm. Afterwards, they need, of course, testosterone suppletion as well. Mind the offspring. For those with obstructive problems, think about mucoviscidosis and the CFT of Those with azoospermia, they think about the AZF on the Y chromosome. Those with spina bifida think about the higher risk in the offspring and folic acid, which is important for both patients. Those with hypospadias think about the Wilms tumor gene as well. Several patients we know, and this is maybe a bit more easy, they come with an undescended testes. And when we have an adolescent patient with an undescended testes, what do we have to do? Do we have to take the testes out? Do we preserve the testes? Do we leave the testes where it actually is? Yeah. Well, it's important. In a general patient without a high ASA score, the risk of dying from testis cancer or dying from the operation, the inguinal orchidopexy, well, those two curves cross at the age of 60 in an ASA 1. So therefore, we always have to balance the germ cell and the mortality risk with each other. Yeah. An adolescent with an undescended testes, do we perform an oncobiopsy? Do we perform observation? And what are the anticipation of fertility? It's actually quite important. If we have an increased cancer risk and mortality, an orchidectomy is definitely better. If they have a single undescended testis, they are far into puberty, and there is a high risk of getting a testicular cancer, an orchidectomy is probably the best. But some patients really want to keep their testes. It's all fine. You can bring them down. But you have to make sure that they examine their testes regularly to be on time when a testis cancer will develop. Yeah. So you always have to balance the risk about an orchidectomy and an orchidopexy observation. So for an undescended testis that is not palpable and unilateral, our approach is maybe a little bit more different. For a non-palpable unilateral testis, we need a laparoscope to assess the abdomen. And sometimes we see vessels entering the inguinal canal. Sometimes we see blind ending vas and vessels, and sometimes we see an abdominal testis in this kind of patients. Well, when we see vessels entering the inguinal canal, we need to do an inguinal exploration and then remove the testes or bring it out. When we see blind ending vas and vessels, we close. We don't have to open the inguinal canal. But when we see an abdominal testis in an adolescent boy, we actually recommend to do a laparoscopic orchidectomy. There is no way to do a two-stage Fuller-Stevens operation as we do in small babies, because in all the testes that I removed laparoscopically over the past 15 years, they were all Sertoli-only syndrome, which means that they don't produce any sperm cells. So why keeping these kind of testes? When there is no testes, we can put a testicular prosthesis, but that's just for aesthetic reasons, of course. Some of our patients have small testes. They come with delayed puberty, they come with gynecomastia, they come with a slow, non-progressive pubertal development. Sometimes they have hypospadia, sometimes they have macroscopic hematuria, sometimes they have bilateral unpalpable testes. Well, in those patients, we always have to think about DSD. They have small testes. If the FSH and LH is low, hypogonadotropic hypogonadism, as I just discussed, or late puberty, another option. Yeah? So it depends on their age. We can wait and we can see them again. When the FSH and the LH is high, we have to check their karyotype. And then there are a few options. We can have a 46XX male patient. Sometimes they have an SRY gene translocation to the X chromosome. Or we can have a 46XY patient. Yeah? Or sex chromosome aneuploidy, like for instance, Klinefelter, or this 45X, 46XY patient. But it's also possible that the testes are bigger and we have gynecomastia. You can see here on our flow chart. These patients need very extensive investigation to try to find out what is happening. And you can see all the tests that we have to do here and all the different diagnoses that we sometimes have to give to these patients. I mean, this is actually fruit for expertise centers. So that's pretty important to take care of that. But there is always a risk in those patients with 45X, 46XY, for instance, that they develop gonadoblastoma into their intra-abdominal street gonads, and that's also the reason that they need laparoscopy to remove these gonads. When you find a DSD patient, always important to refer them to a center of excellence because of the high malignancy risk. But the question is, in those patients with disorders of sex differentiation, what about their fertility? Well, most of them have impaired fertility. There is one study, the DSD Life study, which is pretty interesting, and there we can see that 3.5% of this population had children without assisting reproduction, and that were mainly the congenital adrenal hyperplasia patients, and 7% with assisted reproduction. But it's important to remember that this study is done on patients that grew up in a time that we removed a lot of gonads. Every patient with DSD and a Y chromosome, DSDY, gonads were removed because of the risk of gonadoblastoma. Nowadays, it's not like that anymore. When patients are growing up, we have a tailored approach, and especially for those with androgen insensitivity of these genetic gonads, biopsies are taken to assess the cancer risk, and then is discussed what we are going to do with this kind of patients. Our webinar is not about these patients, but is a very good reference paper that will explain this completely in full detail to you. Because we have to keep in mind that by removing a gonad during adolescent development, we also remove the possibility to father children afterwards. So for all the patients with disorder of sex differentiation, information and psychosexual counseling is very important. The DSD Life study made clear that many of our DSD patients didn't get that much information about fertility and all the possibilities about ICSI, possibilities about TZ and things like that. We needed individualized treatments, but not in every country all these techniques are reimbursed, are available, and it comes with a lot of costs. So especially our DSD patients who want to father a child, it's also best that they are seen in an expert center. Those with congenital adrenal hyperplasia, and it's a special cohort of patients, they sometimes can develop testicular adrenal rest tumors in the testes close to the rete testes, and that's what you can see on the image over here. And it feels pretty hard, and we sometimes think like, okay, this can be a testicular tumor or a Leydig cell tumor. Well, especially when it's bilateral and close to the rete testes in a patient with congenital adrenal hyperplasia, often this is a tart lesion. And when we see a tart lesion, often this is because the patient is not compliant to the hormonal treatment he is receiving. Sometimes we have to optimize the glucocorticoid treatment. Surgery we rarely have to do. Sometimes when we see very extensive tart lesions, sometimes a partial orchidectomy can be performed, but this is extremely controversial. I did it in a few patients. But it is controversial. It's only in those with a huge lesion that have pain that we sometimes remove it. Other DSD patients with partial congenital genesis, it's very variable, their fertility. Most of them are azoospermic, but not all of them. Those with ovotesticular DSD, so they have actually a combination of both, it's usually the ovarian part that is preserved better. So we better keep that to make them fertile afterwards. And those XX males with or without an SOI translocation, there is no single patient published so far, at least as far as I know, that ever developed sperm cells. But again, all DSD patients, when we want to check their fertility rate, please refer them to a center of excellence. What about fertility preservation in our cancer patients, our younger cancer patients, or in those with neurogenic issues? Do we have to preserve the sperm cells before they get too old for that? Well, cryopreservation of spermatozoa is absolutely possible, especially in those who develop cancer. But when do we start developing sperm cells? You see here the different tenor stages from 1 to 5, which patient is actually producing sperm. Most parents will say, when you say, okay, we want to check, we want to preserve the sperm, especially when we start chemotherapy in a 14 or 15-year-old, the parents usually say like, yeah, doctor, but my son doesn't masturbate already. And also when you ask the son about masturbation, especially when the parents are there, they will say no. But there are also a lot of boys that even are not aware about what the word masturbation means. Therefore, speak their language. Privacy. Talk with them one-to-one, and just assume they do, because they all do from a certain age and a pubertal stage. Yeah? And it's also interesting to get familiar to the words that the boys use, and these are the Dutch words that we often encounter in clinic. They don't know what masturbation is, but some of these words they remember. So try to be part of their generation and speak the language they speak. The no-fap community, well, most of these boys are not part of this community. Most of them do masturbate quite regularly, even if the parents think they don't. Yeah. And this is an interesting slide to look at the start of puberty, the start of masturbation, the first ejaculation, and the first intercourse. And usually 1.5 years after the onset of puberty, yeah, possible that you will find some lively cells. Yeah. And also here on this slide, you can actually see that most of them that are azoospermic are the ones who are 12 years old, but once they are beyond 12 years old, in most of them we can find sperm cells. In those we can't find sperm cells, and I'm not going to go in full detail, but also for them, cryopreservation of spermatogenital stem cells is possible. There's not that much we can do right now, and it's quite experimental what we can do in the lab. But especially in animals, we have very good results already to use these spermatogenital stem cells later on. And when we have a 10-year-old that needs chemotherapy, before he needs his sperm, it will be 10 or 15 years ahead of time. So if you can do it easy and collect some spermatogenital stem cells and freeze them, you can use them later on. So it's important to discuss this with the patient. So cryopreservation of spermatogenital stem cells in prepubertal and adolescent boys in early puberty, think about it and discuss this with your patients. Do we have to cryopreserve sperm in our neurogenic patients? Well, we know that for patients with spinal cord injury before the age of 9, it will interfere with their spermatogenesis. When they have a spinal cord injury before they were 9 years old, yeah, they often don't develop sperm. When the injury is close to puberty, often we have similar results as an injury in adulthood. So that's even better. So probably there is a neurogenic control of the spermatogenesis as well. Well, then we often say, okay, for the spinal cord patients, there will be a decline of sperm quality. So let's collect sperm when they are 17, 18 years old, right after the spinal cord injury. Well, actually, there is no specific proof that the sperm will decline in those patients. More free oxygen levels, more DNA fragmentation, we actually don't know, but there is no proper decline of sperm in these patients. I will come back to that in a minute. But there's another thing. In those patients with neurogenic issue where we do cryopreservation and we look at the results of fertility or pregnancy with a cryopreserved sperm cell, well, in the normal population, there's not a huge difference between a fresh and a frozen sample. but in the neurogenic patients, there is a difference. So not sure if we need to cryopreserve sperm in those patients with spinal cord injuries. And what has been proven is that neurogenic patients who get vibratory stimulation for 3 months, that after 3 months of doing it weekly, they get higher concentration of sperm cells, better progressive motility, a decrease in abnormal morphology, and an increased penetration capacity of the sperm cell. So that probably means that in neurogenic patients, when you let them ejaculate more with the help of penile vibratory stimulation, you actually get better sperm quality. Unfortunately, about spina bifida patients, I didn't find any study regarding to this. And usually in spina bifida patients, sperm quality is poor. They have bad bladder management, irregular infections, which increases DNA fragmentation and so on. And especially in those with lesions higher than T10, often they are azoospermic. But maybe when they get more penile vibratory stimulation for a longer time, maybe they do better afterwards. I don't know. I didn't find any study regarding this. And this is a summary slide of those with the lower lesions. The ones with the lower lesions and intact reflexes, they actually do well. In summary, assess sexual function, assist in sperm collection. When there is no sperm in the sperm collection, think about the pre-testicular, testicular, and post-testicular issues. Stick with them about the female side of things as well, and the type of assisted reproduction we can offer afterwards, and about the role of cryopreservation. This is what I wanted to discuss with you right now about the assessment of fertility in congenital lifelong urology patients. And I'm quite sure there will be a lot of questions. Yves is going to moderate, and Pippa, Kris, and myself will try to answer the questions and discuss the cases. Yves, the word is yours.
Let's see if it works. Yes. So we already have some questions, but also some, or maybe some statements. But since we only have 8 minutes left, I think it will be best to start with a case. The most popular case was the case of the 14 or 15-year-old boy with a bilateral undescended testes, one in the inguinal canal, one in the pelvis. Maybe I'll ask Pippa how she would proceed with such a case.
Thanks, Yves. I mean, I think the important point here is actually find out what the 14-year-old knows and what he wants. For a lot of these children, this is the first opportunity to come and start talking about things like fertility, like hormones, puberty, penis. It's a really good opportunity to start that transitional talk from children into adolescence. And so I don't tend to make any big decisions with these children or these adolescents at an early stage. So we would meet several times before we had one. So in someone who had a bilaterally undescended testicles, just like Gunter said, you know, we've looked at trying to see, is there ever any sperm in the abdominal testicles or in the pelvic testicles, and we've never found sperm. So for me, I'm obviously always thinking about fertility potential. In young men who have a testicle in the lower inguinal canal, we'll think about considering trying to bring it down into the scrotum before thinking about doing any kind of surgical sperm retrieval. So his testosterone level is good at 14. He might not want to give himself medication every day. And if you're going to start taking out testicles, even abdominal testicles can be making testosterone. What are his views about having to take a medicine every day or have an injection every few weeks and few months? So often in these young people, it's just the first discussions. No decisions are made for a good few months. Gunter, do you take that differently?
Well, yes and no. I mean, I look at this boy and okay, I don't see a nude picture to assess his tender stage, but just looking at the muscles he has, he is already clearly into puberty, which means that, as you said, the abdominal testes will have a Sertoli-only syndrome, so that's of no use. And yes, he will probably still produce testosterone via that abdominal testes. You're right about that. I think regarding the inguinal testes, I will do exactly the same as you do. We have a lot of discussions with these boys, and I think I would also want to bring it down. And after the testis is down, I will teach them to do regular testicular examinations. That's what I will definitely do, because there is a higher risk that they develop a tumor, so they have to know how to examine the testis and how to contact us when they feel something. Regarding the intra-abdominal testes, to be fair, I don't offer MRI in these kind of cases. When I don't feel a testis, I mean, I will perform laparoscopy, because especially into puberty, the risk of developing a cancer in an abdominal testis is pretty high. And yeah, I think I would take the abdominal testes out at a certain point. Maybe not in the authority.
Can I ask a question, Gunter? It's a question somebody asked in the question box. In fact, the risk of malignancy, you say it's pretty high, but do you have like absolute numbers of the risk of malignancy of such abdominal testes?
Yes, we have. So 2 years or 3 years ago at the EAU in Amsterdam, we gave a presentation about the adolescent abnormal testes, and we reviewed the cancer risk. And for that abdominal testes, I believe it's 52 times higher than the normal population. So that means that for an intra-abdominal testes, I mean, I would not like to leave it in place. Maybe yes, during pubertal development, but not in their 20s, 30s, and usually I take it out. If they have a good functioning testes at the other side, I'm not that much afraid about their testosterone levels. But in this case, it's a bit tricky, because both testes are not down, and we don't have any information about the size of the testes in the inguinal canal. So it's difficult to answer here, but they have to be aware of the risk. And by not taking it out and they developing a cancer when they are 17, 18 years old, it's quite tricky as well, because we will be late in diagnosing it.
I think that's a really good point, Gunter. You know, I think the testicles need to come out, but if you can help them through puberty to the point that they are then developed, comfortable, confident, then we can move forward. I mean, we haven't spoken about, do you organise a semen analysis in these patients? Obviously, if a patient had bilateral abdominal testicles, you know, you're not going to find sperm, but occasionally in the lower inguinal canal, you might see sperm in an ejaculated sample. And I think it's a really important point for us to discuss today. So I get a lot of young men who refer to see me who've been asked to produce a semen analysis sample, fairly on pattern, not much discussion, not much thought into it. Asking a child to go into a laboratory, masturbate and produce a sample is a big thing, and I don't think that we should underplay that. That can be quite a significantly upsetting thing for a child. I want them to be masturbating and enjoying it for the rest of their life. I don't want them to always be thinking about that laboratory and that time that we told them that they were infertile. So it's a really important discussion that we have. So just like Gunter, you know, I will talk with the parents, and then I'll often talk with the boy alone. You know, is he masturbating? Can he produce a liquid? You know, is it something he's doing regularly that's already part of his life? Then we'll think about, you know, doing a semen analysis. But, you know,
what do you think is the optimal time to do a semen analysis in like a 14-year-old boy like this? And are there concerns regarding legal consent starting from 16, 18? When can he consent for such a procedure?
Personal, I think I totally agree with Pippa, and also I don't care that much about their sperm cells right now. I mean, as Pippa said in the beginning, we bring the testes down and let it further develop. Let it develop. Often when you bring the testes down, it starts developing further. And I mean, as long as the boy is not concerned about his fertility right now, I'm not sure if I want to know how much sperm cells he is already producing. When you do a semen sample, often you will not find a lot of sperm cells in these early pubertal stages, and then you give him a stamp that he doesn't have a good semen sample, and that has a huge negative effect on his mental and sexual well-being as well.
I maybe also have a question for Kris, but I'm not sure if he's still here. If he's here, or we can see him or hear him.
Yeah, hello,
there he is.
I'm here.
So maybe 10 years later, and this boy is 25, then he wants to have a kid, and he's been trying for like 1 year, and the sperm sample shows an extreme oligospermia with maybe a couple of hundred sperms. When it comes to the fertility department for assisted reproduction, and they probably will go for ICSI. What do you prefer? In fact, do you prefer then the sperms from his own produced sample, or do you prefer testicular sperm in such a case?
If I have motile sperm cells, I would prefer the ejaculated sperm cells. Yeah, definitely. Yeah, and certainly if we have very low numbers, it's not so sure that we will find in a testicular biopsy we will find any sperm cells. If the production is localized in the testes, and you have an you take a piece of the testis that's not producing, then you end with no sperm cells. Anyway, if the sperm cells are vital, are motile, I would go for the ejaculated sperm. Yes.
Okay. It's about time. I think it's 7 o'clock.
Maybe we can go on a bit. I don't know what Darren says on it. If there are more questions,
We can go on a few more minutes. It's fine. The webinar won't cut off, so we can go another 5 minutes. Everyone's okay.
Is it worth going to the second case, Gunter?
yeah. The second case, is it the extrophy patient or the Klinefelter patient? What was the vote? I don't remember.
The second case was second most popular was a bladder extrophy patient. 25 years, closed bladder neck, Mitrofanov stoma, and he comes with his girlfriend with questions about fertility. So I again look to Pippa. I think, how would you proceed with this case?
This is the case that I'm referring to you, Pippa.
I mean, the ability to ejaculate is quite variable in these patients. Obviously, if they've had an operation on their bladder neck, then chances of being able to produce sperm. What are they able to do? Are they able to have sex? And then you need to examine where the testicles are. We know that we can often find sperm, but it might be that this is going to be the case that we're thinking about testicular biopsy. I think, again, often the first consultation with these patients is not so much about big decision making, but it's talking to the couple. There's things they need to know, and I understand, we've got people all across the world here, but in the UK, what I want to do is educate them about how you would go about thinking about having an IVF or some form of assisted reproductive cycle, because it's not straightforward and it's not cheap. There's very strict rules in terms of age, the partner's BMI, whether they've had children before. So there's a lot of chat really about the female, because the IVF the funding and the process will go through her, and so trying to educate them about these are the steps. But obviously, the most important thing is where we can get the sperm from.
Gunter, any comments?
Yeah, I totally agree. Yeah, this is a case. I mean, he has a phalloplasty and a glans. He has a closed bladder neck, and that makes it a little bit more different. Some patients with bladder extrophy, they have an open bladder neck, and then we really have to think about retrograde ejaculation as well. But in this case, I totally agree with what Pippa says. Often we will need sperm cells that come directly from the testes, but how we approach it legally is totally different from country to country. So there you actually have to know the rules in your own country. I think. In Belgium, for instance, if the patient gets an IVF or an ICSI, I mean, there is no difference in price in Belgium. Correct me if I'm wrong, Kris, but I know that in several other countries, there is a huge difference in price. So we all have to look at the rules in our country as well when we are going to approach this kind of patient.
Okay, I'm looking at the questions. There's quite some questions or statements. Let's see. No real questions about this case, first sight.
I mean, I'll just add in, so if someone's had a phalloplasty, if there's a penile implant, things that we are often concerned about is obviously, doing any kind of surgical procedure, doing a TZ, doing a PISA, can we increase the risk of getting an infection in the implant? These are difficult patients anyway, particularly if they've had phalloplasties. There's a whole load of risks that we need to weigh up. So there's many discussions that need to start with these patients.
It's not only about his fertility.
No, Alloplasty and implant is precious.
Yeah, sure. All right. I think the 5 minutes are also about up. Maybe it's time to wrap up. We discussed 2 cases, which I think is pretty fine. The presentation was really fine. Gunter, any last comments?
Well, I mean, 1 hour is not that much for a topic that maybe from many of the attendees is not a very familiar topic. But I think you can find our email in the presentation, and we are all happy to discuss things if there are certain questions. And as our ERN people also introduced, there is also the European reference network to discuss certain pathologies. But it's a lovely topic. It's very nice to see children growing up thinking about sexuality and then thinking about having kids, and to just grow up with them and to try to help them with all these issues. It's very nice to do. I really like this kind of job, and I hope I could provoke that interest in these attendees as well. Thanks for attending.
Yeah, thank you, everyone. So just quickly, if anybody has further, so what I'll do for the presenters, I will forward you on all the questions. We'll have a report with all the questions on as well. If you want anything else you want to comment on later, if anybody has any questions later on, yeah, you have my email address as well. I can pass questions on. And also, if anybody's watching this on YouTube, the recording, you can also put questions in the comments there. Our business manager monitors those as well. So if you want to ask something, please feel free. Just a reminder to everybody, all the attendees, that this webinar has been recorded, so we'll send out that recording tomorrow. It's also accredited, so please, if you do want your accreditation, you'll need to fill in the survey, which you'll get shortly after this. Please also check out our website. So I think that's all the admin messages. So I'll say thank you very much to Gunter, Yves, Pippa and Kris for taking the time to do this presentation today. It's much appreciated. Thank you to everyone for attending, as ever. Hopefully you'll join some of our future sessions as well. So yeah, thank you guys. I don't know if there's anything else I want to say just before we go, but otherwise, thank you very much for your time. Otherwise, yeah, say everyone have a good evening and thank you very much, and see you all again soon, hopefully.